This meeting is recorded.
My humble request to every one of you, kindly mute your mic. When time comes, we'll ask you to unmute yourself. At present moment, Dr. Somnath, please mute your mic. Dr. Pratap Paul,
Yes, sir.
mute your mic. Every one of you, please mute your mic. Dr. Muruganadam,
Yes, sir.
please mute your mic.
Maria बिल्कुल पेन चल रहा है स्क्रीन का स्लाइड्स में
Various issues regarding the basics of echocardiography. As you can see on screen, we always put a name, age, height, health, then coding of a cases, and look, this is what has exactly happened in the screen. We have a height, weight, body surface area, and everything formulated in the screen. We can put in a blood pressure, like his blood pressure is 130 by 80 millimeters of mercury, and then we create one of the new patient's record. Now we are all set for evaluation dates. Electrocardiogram, the most important parameter for looking at the evaluations, and we are getting the electrocardiogram being hooked up in this subject. And my humble request is, please do not disturb in between. Once we are done with the session, I'll ask you to raise your hands, and once you raise your hands, I'll be able to answer all questions one by one. Please listen to us and please do not open up your mic. My humble request is, today my IT persons are very strict. They will bump you out immediately if they found your mic is open. So now we see this particular ECG. We have a heart rate of almost 100 beats per minute. And we can see a side of a screen. The second screen is out. Target. Now in the side of the screen is, you can look at very well. We have a subject who's lying down over there. Look at his chest now. We have his chest right over here. That is left third intercostal space. It's just below the index mark. Terminal angle, it's here. This is This is 9 o'clock. This is 3. So I'm going to put my transducer. Here's a transducer which has got an index marker over here. This is the footprint of a transducer. You can see the index footprint of a transducer. This is the footprint of a transducer. This is the index marker of a transducer. So first Black's window is third intercostal space along the sternal border, index marker at 11 o'clock position. So, and you can look at it like this is what the parasol long axis view is. Immediately you can see. Just click on Drop Institute if you are not able to see it. Go to gallery, and once you go to the gallery and then click on Drop Institute, double click on Drop Institute, the screen will open up automatically. So this is how we look for a parasonal long axis view. Somebody has said index marker is not seen. We'll show the index marker again. If you are not able to see your screen, go to gallery, double click on the Drop Institute. You'll be able to see the screen. So we'll be able to show you the screen. We'll be able to show you the chest of a patient. Anybody who cannot see a screen now, just post a message. Okay, this is what we are talking about. This is a classical Plaques view. Parasol short axis view at LV at third intercostal space. Here is a transducer where we keep it over here. This is the RV free wall. This is RV. This is anterior aortic root. This is posterior aortic root. Here is the LA. Here anterior aortic root is in continuation with interventricular septum. Posterior aortic root is in continuation with AML. LA free wall is in continuation with posterior wall and EMR. So all the structures which are seen over here they are seen over here. We are not really concerned about the structures. We already know about them. Our issue is that how to make these views are. Look, I'm showing this image again. Can you see my transducer? This transducer is at 11 index mark at 11 o'clock position, left third intercostal space, and just close to sternum, mediastinum. Absolutely 90 degrees at 11 o'clock position. If this item, what we get is we get RV-RA inflow. Here's a Plaques view. Look at the mediastinum, we get RV-RA inflow. Left shoulder, then what do we get is we get RV-RA outflow. This is inflow, and we get RV-RA outflow. RV-RA outflow. So here is a Plaques view. This time here is a RV-RA inflow view, and here is the RV-RA outflow. And holding this transducer over here, if I rotate it 90 degrees, look, I'm rotating it 90 degrees. I get aorta into the center. This is aorta in the center. Here is the RA, here is the RV, RVOT, proximal and distal, then pulmonic artery. And here is a pulmonic valve, here is a tricuspid valve. Left coronary artery is very well seen in this patient. Right coronary artery over here. Now look at the footprint. It's looking towards aorta. Now I'm going almost 90 degrees right over there. So it starts in the mitral valve. So here's the mitral valve. If I go towards his left hip, I'll go to the first papillary muscle level. Now you can see a papillary muscles. Both papillary muscle, one over here, second over here. And third is we go to the apex, and this is what the apical segment is when the footprint is looking towards his left hip. Come back to papillary muscles, then plaques view. This is how we make it. I'm going to show you again. Plaques view, medial standard tilt will make RV-RA inflow view. So this is RV-RA inflow. Opposite side will open up RV-OT. So here is RV-OT. Plaques view again, rotate 90 degrees at aorta. So this is aorta. Then at mitral valve levels, here, papillary muscles, and finally the apex. So these are all 6 views of the plaques window. Once we look at all 6 views, then we go to the apical window. Same patient. Next week, keep your transducer as parallel to the heart as possible. Look, I'm in third and fifth intercostal space. My transducer is as parallel to the heart as possible. And we see a good amount of respiratory movements. So don't go with the respirations. Just hold your transducer wherever you are. And now you can see this is septum, this is lateral mode, and this is anterior leaflet, this is LA, this is LV. Here is an aorta, here is RA, here is RV. And look at the movement I'm taking away my hands. This is left fifth intercostal space. If my footprint start looking towards aorta, so the aorta opens. Otherwise, footprint getting away from aorta, so it's the aorta closes and becomes four chamber. Now look at the rotation. I'm doing counterclockwise rotation of the probe so that the index marker comes from 3 o'clock position to 1 o'clock position. And further counterclockwise rotation will give me a 3-chamber view, which is as if it's a plaques view in a standing position. Correct? Same structure. Here is LA, here is LV, here is aorta. This is anterior septum, this is posterior wall. The papillary muscle is same, it means is inferior. If there is no papillary muscle seen, this is posterior wall of the LV. So we go back again. I'm in perpendicular. If I'm perpendicular, something like this will happen. I have to be almost parallel to the heart. Once I'm parallel to the heart, my footprint is looking towards aorta, the aorta will open. I close my aorta, do a counterclockwise rotation. This becomes 2-chamber view. Further counterclockwise rotation will give me 3-chamber view. And this is almost like parasol long axis view. Only fact is this is standing and parasol long axis view was lying. Look, these are two contemporary with each other. One is the lying parasol long axis view, other is standing parasol long axis. This is what LV, LA, aorta. LA, LV, aorta. We do not see a RV, very small tiny RV seen over there, but to a large extent we can see an RV. So, 4, the apical width. Then next is ask the patient to lie down flat, see the later. Now focusing on the subcostal window. Look, legs are bended up to relax the abdomen. Once the abdomen is relaxed, we go to subcostal window Again, parallel. So your position slightly towards then right side of the heart. So what we see over here is, you can look at my movement. This is my RV free wall. Here is my tricuspid valve. Here is the RA. And if I do a counterclockwise rotation, I'll be opening up his IVC. Namaste. So here is an IVC which opens up. Not a very good view for IVC, but this is where the IVC is. So this is IVC. So this is what is a subcostal window, RV free wall, tricuspid valve, RA. This supracernal window. How do we look at supracernal window is supracernal area, xiphoid process over here, sorry, supracernal window over here, index marker over here, kept at 1 o'clock position. And as soon as we keep an index marker at 1 o'clock position, what do we get? Here is an ascending aorta. So the blood is flowing. This is ascending aorta. And this is descending aorta. So blue away, red towards. Bart is the word. Here is the ascending aorta and here is descending aorta in the same subject. What windows we have to begin with? We have plaques, then apical, subcostal, and suprasternal window, what we have in the subject. Now, as far as 2D image is concerned, any questions from 2 dimensions imaging? Raise your hands, just don't jump asking the questions. Neeraj Dodke, unmute yourself and ask the question.
Sir, please once again show the suprasternal view.
Suprasternal window is very simple. Here is the suprasternal window. This is a probe which has got index marker. I am keeping it right in the suprasternal window with the index marker at 1 o'clock position. And now aorta will go like this. Turns around and then posteriorly. So once in one plane, I'll be able to see ascending aorta, the other plane I'll be able to see a descending aorta. Ascending and descending cannot be seen same plane. They'll be seen in one plane. Here is ascending aorta. And the best part of ascending aorta is switch on colors. They'll be all red in color. Best part of descending aorta, they'll be blue in color. And that's how we look for.
For ascending aorta, do we have to tilt towards the left, sir?
Right.
For descending towards the right.
And look at this anatomy of the patient's chest. It's an aorta which arises, goes up. So aorta ascending is slightly towards right hand side. Descending aorta is slightly towards left hand side. So once you keep your transducer, it will be like slightly tilt towards right hand side. And when it tilts towards left hand side, then you find it descending aorta.
Okay, thank you, sir.
Dr. Ravi Bala Mahajan.
Sir, please once again RARV outflow view and subcostal view.
Subcostal view is very simple. Put your hand in the subcostal region, right?
Yes, sir.
Keep the transducer almost flat to the chest of the patient, slightly facing towards right hand side, index marker at 3 o'clock. Is that okay?
Yes, sir.
Then what do we do is we have to go to the heart as parallel to the heart as possible. So as soon as we go parallel to the heart, we'll start seeing this RV free wall.
Yes, sir.
Counterclockwise 90 degree. You'll see a IVC. Not seen very clearly in the subject, but here is what you see an IVC.
Yes.
Right? Then what was the next question?
Sir, RARV outflow view.
Where is outflow? Outflow is left side of a chest, correct?
Yes, sir.
Inflow is on right side of the chest.
Yes,
If
sir.
I keep my transducer over here, 11 o'clock position, if I move it towards mediastinum, that will be inflow view.
Yes, sir.
Correct. Here is what I outflow view. You can see this outflow view here. So you move your transducer in opposite direction. It will outflow.
Sir, I cannot see probe movement, sir.
Now see the probe movements.
Yes,
So
sir.
this is Black's window.
Yes, sir.
This is classically a Black's window. Just a minute. I will try to make it from the left hand. So this is Black's.
Yes,
The
sir.
footprint looking toward mediastinum will open up here RVRA.
Inflow view.
Right. And footprint looking toward the left shoulder will open up your outflow. Pulmonic valve over here.
Okay. Thank you, sir.
Same continuation, ascending. Look, this is an inflow view. This is all inflow view is. Tricuspid valve, RV, outflow proximal, outflow distal.
Sir, how to differentiate outflow proximal and distal?
Distal outflow is just before the pulmonic valve. Anybody would like to ask some question before I go ahead to Dopplers? Okay, one more. Dr. Surendran. Go ahead, Dr. Surendran. Sachi Surendran. Next is Dr. Gunjan Valsangi.
Good evening, sir. Sir, I have a query. Whether these ECG leads, how these ECG leads are applied. These are the three leads. They are attached to UHG machine.
They're attached to what?
Sonography means echo machine.
Yeah, they are attached to echo machines. And
It
this
is
is
given.
only available in echo machines only. It's not available in ultrasound machines.
Okay.
Ultrasound machine, if you're doing an echocardiography, believe my words, all your diagnosis would be wrong.
Okay, sir. Yeah. Okay. Yeah.
All right.
Thank you, sir.
Dr. Sachi Surendran, any questions from him or her? I don't know. Anyways, there's no more questions. Let me go ahead further. Now, two things what we talked of is we talked of Dopplers. First of all, I'm going to go to a Plaques window. Where do we see a Dopplers in Plaques window? Only one Doppler which is seen in Plaques window is parasite short axis view at aorta is the pulmonic valve. Remember this very important fact. Here is a pulmonic valve. And the principle of color Doppler is blue away, red towards. So in this case, blue color would be seen
सर आपकी आवाज चली गई एकदम से.
You are not audible, sir.
Now you can hear me?
Yes, sir.
Yes, sir.
Yes.
Yes, sir.
All right.
Yes, sir.
Yes, sir. Audible.
So what we were discussing is we were looking at the flow velocity across the pulmonic valve leaflets. When we are looking at the flow velocity of the pulmonic valve leaflets, is we go to parasol short axis view at aorta. From flax window, I'll rotate my transducer to clockwise. So this is what is a parasol short axis view at aorta. Look, this is flax view. Again, I'm going to change the colors. So this is flax view. Take transducer 90 degree, aorta in the center, and here is the pulmonic valve. You can see my cursor. And this is before the pulmonic valve is RVOT. Distal to pulmonic valve is pulmonic artery flow patterns. And this is very important window for calculating pulmonic flow gradients, pulmonic regurgitations, and no other better window is seen except this pulmonic valve. On the other hand, you can see this colors in the tricuspid valve leaflets. See a colors in the tricuspid valve leaflets. So here is a tricuspid flow. That is RV, RL flow view. Is a tricuspid valve flow way. So two places where we see in parasol short axis view at aorta. One is a tricuspid valve. Second is a pulmonic valve. Now I'll come back to flax window again. Here I can't look at my Doppler flow because we are almost perpendicular. If I go to the mediastinum, again what I'll be getting is I'll be getting RV, RA inflow. So here is RV, RA inflow. Correct? Then come back to flax window. There is no other place. If you want, you can do this RV, RA inflow view, and opposite side you can look at pulmonic artery flow patterns. So here again, this is RV outflow tract. So you can see the pulmonic artery flow patterns. Important part of a color Doppler, as we told you earlier also, and the same thing right now. Look at this color scale on the right side of the screen. This is red 61, blue 61 centimeters. This is based on an assumption that violet, indigo, blue, green, yellow, orange, red. So if we go from a violet color, violet, indigo, blue, so violet, indigo, blue would be here, then green, yellow, orange, red. So if you happen to see this color, the blue color is away and the red color is towards. And red color changes to, as the velocity increases, it changes to green in color. I can change the scale. Let me reduce this size of the scale of a color Doppler. Doppler scale. So this has gone to Nyquist limit of 16 centimeters. And then I can also change the quality of this color Doppler scaling, but we have, this is known as variance scale. So we have to keep it on the variance map. So keep this Nyquist limit at 60. Any velocity which is more than red in color and more than 60 will be reflected as yellow, green, and towards blue color. Next, go to, from this Nyquist limit, we go to what? We go to apical window. Keep your probe as parallel to the heart as possible, as I told you earlier also. I'm almost parallel to the heart. Now look, my probe is, I'm almost parallel to the heart is. This is, I opened my aorta. So this is the third window where you can see the aortic flow velocity. If I have to want LVOT, I have to be before the aortic valve. So here is LVOT by pulse. If I move it distal to the aortic valve, this is known as aortic flow velocity. Can you see the difference now? And whatever you're seeing right now is a very good example. This aortic flow velocity is not contained in this Doppler spectrum pattern. It is seen on the other side. And this is word which is known as aliasing. So what do we do? So we move the baseline up to contain this Doppler spectrum pattern. And as we did, we could see a peak of this Doppler spectrum pattern over here. Right? And you can measure it. In aortic stenosis, the velocity is only 1.7. In aortic stenosis, the peak would be very deep, like 5 meters or 4 meters. So you cannot contain this Doppler spectrum pattern by moving the baseline. Then you have to convert to a continuous wave Doppler. Now I've shifted to a continuous Doppler, and the same cursor does not show any box over here. Now it's a line, which is single line, which you see. It means it's calculating velocity from this point onwards, all the way down wherever the cursor is moving. And it gives you the maximum velocity across this aortic valve. Look, the maximum velocity across the aortic valve is almost 1.67 meters per second. Next point is, we look at mitral flow patterns. So we look at the mitral flow pattern over here. Pulse distal to the tip of the leaflets. And as we do a mitral flow pattern, all of us will understand what exactly are we seeing. We are seeing E wave and A wave also. And we have a ratio. If you want, you can have a ratio of E and A wave. This is mitral flow pattern. In case you have to see a regurgitation, the regurg will be seen behind the leaflets. Now, this subject has got a very trivial minimal regurg just behind the leaflets. This is all regurg he has over here. Then third window is, we look at a tricuspid valve. And looking at the tricuspid flow velocity, which is E wave and A wave. Here is E wave, here is A wave. And then by putting a continuous wave Doppler, I'll be able to estimate by TR jet velocity. See a TR jet velocity, which is something like over here, 2.2 meters per second. So this is 4-chamber view. Rotate counterclockwise, it will become 2-chamber view. Rotate further counterclockwise, it will become 3-chamber view. So if you have to take a flow velocity across aortic valve, You can take either in 5-chamber view or 3-chamber view, whichever is comfortable. Now going to sub-costal window. Sub-costal window, what we see is the most important part is we see an intra-atrial septum out here. This is intra-atrial septum. And counterclockwise rotation will give us IVC diameter. Unfortunately, not seen very clearly in this subject, but we do see a small IVC over here. It's here. So this is all IVC caliper in this subject over here. This is almost 15 millimeters. So counterclockwise rotation of the probe will give you this IVC. And next is go to suprasondal window. Reduce the depth, and here is ascending aorta. Here is the descending. So this is how we look for colors. Once we look for these colors, and then we try to measure the gradients. Look, I am going to measure the gradient across this mitral wall. So I'll take my sample volume, go to a pulse wave, and increase the sweep speed. And now I can place this Doppler spectrum pattern. So what the Doppler spectrum pattern is, beginning of this mitral flow opening, going all the way, tracing it down, come back, go up. This is E wave, this is A wave, and this is end. And here is the flow velocity maximum is 91, mean is 0.54, gradient is 3.31, mean peak 1.38 mean, heart rate 70, and mitral valve VTI is 27. This is how we make peak and mean gradient and VTI. Now I'll ask, can anybody tell me, can we calculate a stroke volume from this mitral valve VTI? We have taught you this. This is theoretical question. So what I'm going to do is, again go to the same thing, go to pulse wave, raise the envelope, mitral valve, EA and A ratio. Now, this EA ratio, if you look carefully, this ratio has got a component of mitral valve VTI, which is 27.29 centimeters. So if I have an area, which I'm going to calculate from this window, so if I have an area, so which I'm going to calculate, here is mitral valve. Look at the hinge point of the mitral valve reflex. This is one over here and the second one over here. So 2.54 centimeters per second. And now we can calculate the stroke volume across mitral valves. This is diameter divided by 2 will give you radius. Square that off into 3.14. Add your RVOT, mitral valve VTI, which is 27.97. Then we give you a stroke across the mitral valve. Similarly, in plaques window, we look at mitral valve area by perimeter. So calculating mitral valve area is perimeter. We have to go towards papillary muscle first and gradually come back to very gradually we have to come back to mitral valve. So this is all mitral valve which is seen over here. And you can perimeterize the mitral valve area, and this is mitral valve area in perimeterized form. This is almost, area is 10.72 centimeter, little on the higher side, but this is how we look for an area. Then you have to look for aortic flow velocity. Same aortic flow velocity is, if I keep my cursor in the proximal to leaflet, this is RVOT flow. If I keep it distal to flow, this is aortic valve flow. So to calculate at aortic or LVOT area, LVOT, we have to keep a cursor behind the aortic valve and use pulsive Doppler spectrum pattern. And here is LVOT VTI. So what we are getting is the area is 1.01, sorry, velocity is 1.01, mean is 0.75, LVOT max is 4.06, mean gradient is 2.48, and the most important thing is LVOT VTI at a heart rate of 70 beats per second. So with this LVOT VTI, and if I have my LVOT diameter, I can calculate the LVOT flow in ml per second or per minute. This is how we look at. This is LVOT. Now let me just save it for you. Same picture. I'm going to take an aortic valve VTI. So what I'm going to do is I'm going to keep my cursor distal to the tip of the leaflet. Now erasing is happening. My line is gone up. So what I'm going to do is switch over to continuous wave. It automatically calculates it for what exactly the formula is. So machine will increase or decrease values. So this is aortic valve VTI. So I'm going to trace the aortic valve VTI now over here.
ಒಳ್ಳೆ ದುಡ್ಡು ಮಾಡ್ತಾರೆ ನೋಡಿ
Aortic valve goes.
ಹಲೋ ಹಲೋ
So this is aortic valve VTI. If I've got an LVOT diameter, I've got a LVOT VTI, I've got aortic valve VTI, I can calculate aortic valve. This is what we do when we calculate the aortic stenosis, aortic valve. Next goes is we calculate again tricuspid inflow view. Now from aortic valve, I'm moving to tricuspid valve. I'll keep it distal to the tip of the leaflets to get E and A ratio of tricuspid valve. So this is E wave, this is A wave, and the ratio is 75 divided by 57 would be the EA ratio in this circuit. Now look at the colors of a tricuspid regurgitation jet. This is focused RBRA mode, and I'm finding some colors over here, and I'm going to keep my Doppler spectrum pattern into the colors. And as soon as I put my colors, look, I'm getting my TR jet gradients of almost 2 meters per second. Right? Next comes the wall motion abnormalities. 4-chamber view, middle basal septum, middle basal inferior wall, and basal septum. This is basal septum. Basal inferior wall. This is apical inferior wall. Apical lateral, mid lateral, basal lateral. Rotate my transmission 90 degrees. What I'm going to get is 2-chamber view. Here is anterior wall, inferior wall. This is anterior wall. Whole of the anterior supplied by LED, apical inferior supplied by LED, middle basal inferior supplied by RC. So I'm going to rotate my image further. Go to a 3-chamber view. In 3-chamber view, this is LA, this is LB, this is aorta. So we have this LA LB aorta, which is almost like a parasol long axis. In 2-chamber view, septum and lateral wall, middle basal septum is supplied by RCA, middle basal lateral is supplied by circumflex, apical septum, apical lateral is supplied by LA. Then comes two chamber view. Whole of the central wall is supplied by LED. Then basal and mid inferior wall is supplied by RC. And if I rotate my transducer 90 degrees, this is what is the picture of Planck's window is. So this is LA, this is LV, this is anterior septum, and this is the posterior. And I'm going to store this image for future references. Okay, so we have seen where we take out a harmonic flow velocity, where we keep mitral, aortic, and tricuspid flow velocities. Now again, questions. I've told you about colors, a little bit of a colors, blue away, red towards, and then once you look at this, now the questions on this, whatever we talked about. Then I'll go to measurements for some time. I know it's a very boring topic, very difficult. Neeraj Dodke.
Sir, I need to know the menu. What did we select and how do we do it?
On a machine.
Like while measuring aortic. Hello.
Yeah, I'm listening to you. Go ahead.
While measuring aortic valve VTI and LVOT VTI, how do we take the trace and how do we do it? What do we select? Because I'm finding problems with that while doing the measurements.
Call you some vendor. Vendor will guide you. Which machine do you have?
Sir, actually, I am having my hospital machine. So that
Hospital machine. Which hospital machine?
Yeah. Hello.
Name of the machine. Name of the company.
I'm not hearing you. Hello.
Name of the machine and a company. Anybody else? Neeraj.k is lost. He'll come back again.
Sir, Logic V2. Hello.
Logic V2 is ultrasound machine. It'll have nothing. You're wasting time on a Logic 2.
Okay.
Ravi Bala Mahajan.
Sir, what is A wave and E wave? I don't understand, sir.
This is the mitral flow pattern. Look at this mitral flow pattern over here. This wave is known as E wave. Correct?
Yes, sir.
Other wave is known as A wave. This is E and A wave ratio. So this is E wave, this is A wave. In relation to mitral valve. Okay?
Sir, what it denotes A wave and E wave?
Wait for some time. They have their own significance. E and A wave is when the left atria empties at the beginning of mitral valve opening or at the beginning of diastole. Initial emptying is E wave.
Okay.
And this is a part of a diastasis. When the pressures have equalized between LV and LA, that is, the blood is coming from pulmonic vein and going directly to the LV, which is known as diastasis. And third is when the diastole is about to finish, the atria kicks, atria contracts.
Yes.
When the atria contracts, that gives rise to A wave.
Okay. Thank you, sir.
Right.
And what is this point?
What is this point means?
At the end of the E wave, A wave with this point, with the baseline, is there any point?
Baseline, this is the point of the baselines. In fact, let me just draw it this E wave, A wave, trace you. Let me do it because I have, unfortunately, my machine has automatic on. AI is on in my machine. So whenever I just look at this, automatically pick it up and measure it as E wave. Good. The tracing. Look, I'm doing the tracing starting from baseline, going across with this E and A wave. This is E wave. Correct? Now I'm coming down. So this is now A wave, and I'm coming down always along with this A wave to the baseline. And this is EA wave. Almost the same thing. But this is how we trace manually. I'm sure many of you must be having this manual record in your machines. Dr. Mahananda Mahatre and then Ripan, Dr. Ripan.
Sir, would you please explain again LVOT Doppler and aortic Doppler, where you will put the sample volume? Cursor where you will put.
Sure, I'll do that. I'm going to 5-chamber view now. Can you see this 4-chamber view?
Yes, sir.
I'm opening my 4-chamber view to the aorta. So the footprint is looking towards right shoulder. Now my cursor is over here. This is can you see my pointer?
Yes, sir.
This is LVOT and this is aortic valve. Before the leaflet of aortic valve is LVOT, left ventricular outflow tract. After the aortic valve leaflet is known as aortic valve aorta. Right? I want to take LVOT VTI. So what I'm going to LVOT is site specific. So I take my cursor at the level of site specific LVOT. And take my pulsar Doppler spectrum pattern and then I'll calculate my LVOT VTI. Look at the screen. What you see in the screen is what you look at the screen is there is a pulse wave here.
Sample volume.
This is known as sample volume. And difference between pulse wave and continuous wave is this pulse wave has got two lines which are separated with each other. Correct? And if I have to take an aortic valve VTI, I'll move this cursor in the next image. I'll move this cursor distal to the tip of the leaflets. So I'm moving this cursor into the aortic valve and then take a pulse wave Doppler spectrum pattern. Look, I'm able to get a good Doppler flow. I am getting a good Doppler flow is because he does not have his aortic stenosis. The velocity is 1.45 meters per second. Suppose this patient has got a severe aortic stenosis, what will happen? This Doppler spectrum pattern will not be contained and be reflected on the other side because of the high velocity, and this is known as aliasing. Then we switch over this Doppler spectrum pattern this wave Doppler because that is the time when we are starting to look at high flow velocity jets. And now I'm doing a continuous wave Doppler. Now look, it's a very clear cut Doppler spectrum pattern which is seen over. Even I can bring down the baseline also. So this is known as aortic valve VTI, and that was known as earlier LVOT.
Yes, thank you, sir.
Clear? So,
Yes, sir, clear.
utilizing a continuity equation in your calculations, LVOT diameter divided by 2 multiplied by pi r square will give you area. Area into LVOT VTI will give you stroke volume across LVOT. This stroke volume divided by aortic valve VTI will give you aortic valve area. Okay. Any other questions?
So, Dr. Gupta, if we calculate the LVOT and LVOT VTI, the machine will automatically calculate stroke volume.
Look, machine has got so many functions. Unfortunately, we do not know about those functions. And we don't switch over this function. Look, my machine has got everything activated. Now I'll show you how it's activated. I'm going to calculate my LVOT dia. So calculating LVOT dia, I have to go to my Platts window. Make a very good imaging quality because this is what is the most important part for any dimensions. Yes. Now my both leaflets are open up.
Yes.
This is one leaflet over here. This is second leaflet over here. And the point where the two leaflets join together, This is known as hinge point. And you join those two leaflets together, that's what your LVOT diameter is. In fact, this is annulus. So at your level, just measure at that level, that will be fine for LVOT diameter. So I'll ask my machine dia. So I'm going to calculate my LVOT dia. And as soon as I calculate my LVOT diameter, look, the machine is giving you mitral area by VTI and other things. That's not correct. So this is LVOT diameter is 2.09. Now I'll go to LVOT VTI. 22.60. So once you calculate LVOT VTI, I'm going to do that again. So what do we see over here? You can see your LVOT diameter and LV stroke volume. Can you see on the screen?
Yes, yes.
So in screen, you can see your LVOT VTI, you can see your LVOT stroke volume, you can see your LVOT dia also. So all values would be depicted right over here. It is giving you stroke volume indexed, cardiac output, and cardiac output indexed. Only thing is you have to switch them on by your vendor. Look, this is how we need to switch them on. And in hemodynamics, there's nothing. You have to look at a peak and velocity, velocity time integral, and pressure half times. Is that correct? I know these basics are very important, but basics are very confusing. Both the things happens together.
Okay, thank you.
I showed you LVOT, how to measure LVOT. Both the plaques window, both the leaflets open up, and then measure the hinge point of those right and non-coronary cusps. Now, same thing you can do in mitral valve. What you can do in mitral valve is, so I'm going to rotate 90 degrees. Take 90 degrees, go to papillary level, and gradually come back again. And now, as soon as they came back from papillary level, now you can see my mitral valve right over here. This is major commission, this is lateral commission, this is AML, this is PML. So I'm going to measure this in measurement, generic measurement, area trace. So I'm going to trace this area of the mitral valve. 5 to 4 is the normal values. And in this screen, this is lateral commission, this is medial commissions. And whenever the stenotic happens, this area will go down less than 0.1, 0.5 centimeters square. Now, next important issue is we look for a pulmonic flow velocity, pulmonic gradients. Look, we talk of pulmonic valve and then we talk of pulmonary artery pressure. Pulmonic valve will give you pulmonic stenosis. Pulmonary artery pressures will be derived from TR jet velocity. Tricuspid regurgitation jet velocity. Can you see this TR jet tricuspid regurgitation? Blue in color. This is what the TR is. Here is the TR. Tricuspid regurgitation. This is, if you measure it, this is almost less than 3.3 centimeters. It's almost 6 millimeter. So it's moderate category of tricuspid regurgitation, moderate tricuspid regurgitation. But the question is, the severity of the regurgitation is not dependent on the vena. This is known as vena contracta. So if I put my colors again, go to 2B, switch on my colors and take my cursor right into the color jets of a blue color. So what I'm going to get is, I'm going to get a tricuspid regurgitation jet. Now with the TR gradient is seen over here, 2.5 meters per second, corresponding to 25 millimeters of mercury. This is tricuspid regurgitation jet against from RV to RA. RA has got its own pressure, which is right from IVC. So 25 from 530, and this is peak pulmonary artery pressure is 30 millimeters of mercury. Correct? From there, we have to calculate mean. 30 multiplied by 0.6 and 2.1 will give you mean pulmonary artery pressure, which is 20.1 millimeters of mercury. This is how we calculate peak pulmonary artery pressure and mean pulmonary artery pressure.
Sir, please repeat.
This is RV, this is RA. This is tricuspid regurgitation. We have kept a continuous wave Doppler across tricuspid regurgitation, and we got a peak gradient across from tricuspid valve to from RV to RA. This is what the blood is flowing from right ventricle to right atrium through tricuspid valve and giving me a gradient of almost 25 millimeters of mercury. But RA has got its own pressure, which is decided by IVC. If you look at the IVC's normal size collapsing more than 50%, we say RA pressure of 5 millimeters of mercury. Suppose the pressures are 5, 25 plus 5 is 30. That is peak pulmonary artery pressure. Now from peak, we have to derive mean. And how do we derive mean is, we calculate by a formula, peak pulmonary artery pressure multiplied by 0.6 and 2.1 constant. So what 30 into 0.6, 18 plus 2.1, 20.1 would be the mean pulmonary artery pressure. Anything more than 25 is considered as raised pulmonary artery pressure. Whenever we talk of pulmonary artery pressure, we always talk of mean. We are not talking of peak pulmonary artery pressure. So at this moment, this is what I would like all of you to digest. Not more than that. Because as we move further, suppose we go to cardiomyopathies. We'll show you calculation of ejection fractions. Then we talk of a diastolic function. Then we talk of other factors like EA ratio, E prime septal, E prime lateral, then LA volume index. So this is how we'll take up this subject further. At this present moment, this is what we are looking forward is to digest this much of knowledge, which is more than enough for today's circumstances. Now, open to questions. Anybody would like to ask questions? We are most welcome.
Hello, sir.
Raise your hand so that I'm able to identify you, and then I'll ask your name and then go ahead. Dr. Neeraj Dodke.
Sir, in the peak pulmonary artery pressure formula, we multiplied the tricuspid valve gradient plus 5 into 0.6. Then we add how much, sir?
No. A very simple thing is, first we calculate peak pulmonary artery pressure.
Okay.
Peak pulmonary artery pressure is TR jet gradient first.
Yes.
Tricuspid regurgitation jet from RV to RA.
Yes.
So RV to RA, that is a gradient of suppose 25 millimeters of mercury.
Okay.
RA has got its own pressure also, which is decided by IVC.
Okay.
If IVC is normal size collapsing more than 50%, RA pressure is considered as 5.
Okay.
So 25 plus 5 will become 30.
Yes.
That is peak pulmonary artery pressure. Now, with this pressure, the blood is pumped from RV to pulmonic artery.
Yes.
Is that clear?
Okay. Yes,
In
yes.
practical circumstances, we are not using peak pulmonary artery pressure. We are using mean pulmonary artery pressure. So whatever
Okay.
the peak pulmonary artery pressure is, we multiply by 0.6.
Okay.
And then we add a constant of 2.1.
Okay. Okay.
30 multiplied by 0.6 would be 8. Add 2.1 would be 20.1 millimeters of mercury. So anything less than 25 millimeters of mercury, guideline says up to 20 is definitely normal.
Mhm.
20 to 25, we have to look at this subject in follow-ups. More
Yes.
than 25 is definitely pulmonary artery hypertension.
Okay. So then what is RVSP?
RVSP is right ventricular systolic pressure, TRZ gradient.
Okay. The TRZ gradient itself is known as RVSP.
Right ventricular systolic pressure. When RV contracts, it sends its blood back into the RA. That is TRZ gradient.
Okay. Okay. Thank you, sir.
Dr. Ravi Bala Mahajan.
Sir, what is vena contracta?
Vena contracta is a hole through which the blood is regurgitating back from one chamber to another chamber. So, in this subject, the word vena contracta is concentrate on tricuspid valve. Don't concentrate anywhere else.
Yes, sir.
Now you can see a blue color spectrum.
Yes, sir. Yes, sir.
And if I have to say this, we have to look at the tip of the leaflets. Now, this is the tip of the leaflets of this blue color, correct? This is tricuspid valve seen over here. So I'll switch on colors again. The blood is flowing from this tip of the leaflet. So what is the width of this color jet, which is known as vena contracta? So color width jet is almost 0.6 centimeter or 6.1 millimeter in this subject. So we in tricuspid regurgitation, we have a like mild, moderate, severe, massive and torrential. 3 to 7 is moderate, 7 to 14 is severe, 14 to 21 is massive, and more than 21 is considered as torrential. And this is value for tricuspid valve repair. How much vena contracta or how much this TRZ is. Suppose the principle of this comes from like mitral stenosis patients. Those who have a mitral stenosis with pulmonary artery hypertension, what will happen? RVRL, they become bigger in size.
Yes, sir.
When the RVRL they become bigger in size, so what will happen to this annulus? This become bigger in size. So you have a tricuspid regurgitation where vena contracta would be large.
Yes, sir.
To correct vena contracta, we put a tricuspid annuloplasty ring to reduce the size of this vena contracta. We'll come to those points later on one by one.
Thank you, sir.
Okay, right. Dr. Ripan,
Sir, where to put the cursor exactly for pulse wave Doppler measurement at the level of mitral valve?
pulse wave Doppler measurement at the tip of the mitral leaflets. Look, I'm going to put my cursor at the tip of the mitral leaflet in pulse wave for mitral Doppler measurement. So I'm going to keep my. Can you see my arrow?
Okay, thank you, sir.
But if the velocity is very high, like mitral stenosis, you have to switch on to continuous wave Doppler. The principle is whenever you can't contain a Doppler spectrum pattern, you switch over to continuous wave Doppler spectrum pattern.
Thank you, sir. Thank you.
Sudhar Rahman.
Adab, sir. I am Dr. Masood Rahman from Bangladesh, sir. I do not see any pictures, sir.
See any pictures?
No, sir. In the whole class, I did not see any pictures, sir.
What you were saying in the whole class, man? Seeing a movie without colors. Man, go to gallery. Right top. Do you have mobile or you have a laptop?
Mobile, sir.
Then it's better not to see anything.
Yes, sir. Sorry, sir.
You can't have a girlfriend as a wife and wife as a girlfriend. So these classes you have to have a laptop, man. So mobile will not be working at all. That's the reason. Anyway, we'll send you a recording, Dr. Mohammed. Bear with us, but next time you have to have a laptop, please.
Okay, sir.
Anybody else? Any questions? All right. So,
Sir, if there are no TR, so how to calculate pulmonary artery pressure?
beautiful question. Who's this person? Dr. Samsul Kumar.
Yes, sir. Yes.
Dr. Samsul, it is said in the life, if you cannot see a TR, it means you are hungry.
Okay, sir.
Or hunt for a food, first hunt for a TR. And for hunting a TR, we showed you only one window. We look at 5 different windows for TR jet gradients. Starting from Plaque's window, we go to RVR inflow view, parasol short axis view at aorta, apical 4-chamber view, focused RVRA view, and the subcostal window. And there is no way that you cannot see a TR jet gradient. But still your question is valid. Suppose you don't get a TR jet gradient, then how do you calculate your pulmonary artery pressures?
Yes, sir. Yes, sir.
Then go for a PR jet gradients, not TR. Then go for PR jet gradient. Let me try in the subject.
Okay, sir.
Good question. Try 5 windows. All of them, very rare that you cannot get a PR jet gradient. Go to PR jet gradients. I've got a very trivial. Let me try if I can get a really gradients. Okay. So I'm going to project that this patient has got, this subject has got a PR. Where do you see a PR and what will be the Doppler spectrum pattern? I'll create the Doppler spectrum pattern by measuring it. So I'm going to trace it. Now I'm going to trace the so-called PR jet. Correct? So this is the peak of the PR jet. So if I have to take this, let me save this image and then I'll bring it back. All right. So I'm going to use my arrow. So this is suppose a PR jet Doppler spectrum pattern. This is early diastole, this is late diastole. Is that right?
Yes, sir.
Early diastole, suppose this is 2 meters per second. This is 1.5. For calculation purposes, suppose it's 2 meters per second. The gradient would be 2 into 2 into 4, 16.
Okay.
Add RF pressure to it, it becomes 16 millimeters of mercury. And this is what 16 is a?
The normal, sir.
No, not normal. This is mean pulmonary artery pressure.
Okay, okay, sir.
16 plus add RF pressure to it, that will be like same 5. So 21 millimeters of mean pulmonary artery pressure. That's how we decide from this PR jet gradients.
Okay, sir.
All right, Dr. Naveen.
Sir, good evening, sir. Sir, while measuring the aortic VTI, there is a small jets between the 2 major aortic jets. So a lot of times we do get the small artifacts, or is it like, how can we minimize it?
Let me go that again. This is your LVOT. Switch on colors and keep your cursor right at the LVOT, right? Then take a pulse rate of it. So there is a 2 jets. We can see a very clearly systolic jet. LVOT is systolic. So this is one systolic jet is there. This is a garbage. Forget about this diastolic garbage. We are not remember LVOT will be flow will be only in systole, not in diastole. So what you look is look at the QRS complex end of a T wave. So what I'm going to do is trace this Doppler's flow pattern across LVOT, and this will be my LVOT VTR. Correct?
Okay, sir. I was confused because of the small jets. Like what to do with the small jets? I was confused.
The small jets are dazzling. These small little low velocity jets, which is shown because of the forward flow. Or it could come from a diastole from other signals. So if you have to LVOT, it should be in systole, not in diastole.
Okay, sir. Thank you.
Dr. Maria Bilkis.
Sir, how to calculate stroke volume for mitral valve VTI? Can you explain please again?
Okay. Stroke volume mitral valve VTI. Very simple way of looking at a stroke volume across mitral valve VTI is. So let me suppose this is my 4-chamber view, correct? So what I need for stroke volume, I need for L. One is area across the mitral valve. So I'll go to the maximum size of the mitral valve is when mitral valve is about to open up, and that is known as mitral valve annulus from one hinge point to another hinge point. So here the diameter is 32 millimeter or say 3.3 centimeters. Is that clear? Dr. Maria?
Yes, sir. Yes, sir.
So one part is we have a diameter. Diameter divided by 2 multiplied by radius. Diameter divided by 2, then square it off multiplied by pi r square will give you area. That area is pi r square. Next part is mitral valve VTI. So I'll go to the mitral valve and trace this mitral valve as shown traced over here. And we got the VTI. VTI is 27.29 centimeters. So multiplied by area into VTI, that gives you stroke volume across mitral.
Okay, sir. Thank you, sir.
Dr. Muhammad Ali Qasim.
Good evening, sir. Can you hear me, sir?
Yes, I can hear you. Somebody mic is open, it's cracking his noises. Please silent your mic. Only open it up when you want to ask some questions.
Sir, is there is pulmonary stenosis? How can we measure the pulmonary artery systolic pressure?
Question. His question is, suppose we have got a pulmonary artery systolic pressure, we have pulmonary stenosis, then how do we measure pulmonary artery systolic pressure? Answer is, whatever your pulmonary artery systolic pressure is, I said peak pulmonary artery pressure, which I showed you over here a few minutes back was, let's see, where is the peak pulmonary artery pressure was, suppose peak pulmonary artery pressure is 36, right? And pulmonary stenosis pressure is 15. So the peak pulmonary artery pressure would be 36 minus 15. That will be your peak pulmonary artery pressure. 36 minus 15 would be 21. 21 into 0.6 plus 2.1 would be mean pulmonary artery pressures.
Thank you, sir.
Dr. Neeraj Dodke, you want to ask again?
Sir, what is the significance of calculating mitral valve VTA?
Good question again. Suppose you have got a mitral regurgitation.
Yeah.
So what we do is we calculate a regurgitation volumes.
Okay.
If you have a LVOT flow, LVOT stroke volume and mitral valve stroke volume, suppose MR is present, the amount of blood which is flowing through a mitral valve would be more as compared to LVOT.
Yes.
Suppose mitral valve flow is 120 ml and LVOT flow is only 60 ml.
Yes.
So where is 60 ml is going? That is the regurgitation volume.
Yes.
It has got a lot of significance when we have to decide about severity of regurgitation. And when we use multiple parameters, this is one parameter we always take into practice. Look, you are at the beginning. When we have to give an answer whether this person has to go for a replacement or repair of the valve, we have to tell them, look, this is really severe.
Okay.
We can't say it appears severe. It's probably severe. It's mildly severe. It's severe means severe, and majority of parameters should collaborate before we ask the person to go for surgery.
Okay. So another thing, while calculating mitral valve VTI, you calculated the area of mitral valve with the formula of pi r square.
Correct.
Will that formula, will that area will coincide with the area of planimetry?
This annulus area is utilized for some particular purposes. Planimetry area of the mitral valve is the leaflet tips.
Okay.
Look, you're talking about two different things.
Yeah. So this area would be won't be used in the grading of the mitral stenosis.
No. Mitral stenosis gradient will be used at the tip of the mitral. This is the mitral valve, annulus. I'm calculating. Leaflet opening is considered as stenotic leaflets.
Okay. So
two different things.
Okay. And while calculating,
just I'll tell you what. Give me a second.
Yeah. Okay.
What you're talking about? I'm talking about this annulus diameter.
Yes.
What you're talking about the stenotic diameter. This stenotic would be here, the tip of the leaflets.
Okay. So when we calculated it by planimetry, it was for mitral stenosis.
When we calculate by planimetry, we'll be calculating the tip of the mitral valve.
At the tip of the mitral valve leaflets, yes.
Not at the annulus.
So that will be used for grading of mitral stenosis.
Stenosis.
Yeah. Another thing, sir, while calculating this area for mitral stenosis, what will be more specific, mitral valve area by pressure half time or mitral valve area by planimetry?
Remember the simple principle, mitral valve area always by planimetry.
Okay.
Whatever that happens, you have to depend, when the hole is small and you can measure the size of the hole, why do you want pressure half time?
Okay. Thank you, sir.
And there are techniques there with which we can accurately measure the mitral valve area planimetry. We have like machines where we have multi-planar transducers. So what the machine will do, I'll just show you in a second. This machine has got the same technology with which we cut right at the tip of the mitral leaflets. Amazing technologies.
Okay.
But they cost a hell of a lot. That's the only problem.
Thank you, sir.
Next time you don't buy a Mercedes Benz, you buy an echo machine.
Okay.
This is a technology which I'm trying to show you now. So what exactly is, I'm going to go on orthogonal plane. Look, I'm cutting aorta. Can you see my aortic valve cutting? And the side, on right hand side of the screen, you see a parasol short axis pivot aorta.
Yes.
Correct. Now I'm going to the tip of the mitral valve leaflets. And you can see the mitral valve leaflets on the right side of the screen.
Yes.
So I can really approximate to the mitral valve leaflet. And this is the most accurate mitral valve area calculation method.
Okay.
This, you can take a caliper and this is all you can trace mitral valve area. Not this. I'm showing you, like, this is not a perfect I'm doing it, but this is how I can calculate the mitral valve area. Perfection.
Okay. And while calculating, we have to calculate from the inside of the leaflet.
Correct. That's what we have taught you, leading edge to trailing edge.
Yes, sir. Yes. Thank you, sir.
This technology is available with 3 dimensions.
Okay.
Dr. Sachi Surendran.
Sir, what is the basic difference between velocity and velocity tissue index, VTA?
Velocity and velocity time integral, not tissue index. Velocity time index, integral. Velocity is a point where the velocity is, you can measure point velocity. VTI is the amount of distance blood traveled with every stroke. Look, if I'm using this VTI, it tells you these many centimeters, 22.6 centimeters, the blood has traveled with every contraction of LV. And velocity is, this is what the velocity is.
Okay, sir.
The distance blood traveled with every stroke is known as velocity time integral or VTI. The velocity is, this is what the velocity, this is peak velocity. And if you average them all velocities together by tracing the Doppler envelope, you get the mean velocity.
Okay, sir.
Dr. Vandana Kumari.
Good morning. Good evening, sir. How to calculate the severity of MR and TR, sir?
Oh, Vandana, just wait for some more time. We have a classes gradually coming up, But I can tell you in a nutshell how to calculate the severity of MR and TR. First, MR is, whenever the MR is very severe, what you should look is LV dilatation. First and foremost parameter. Then we look for vena contracta, more than 0.7 centimeter. Then you look for jet area versus LA area. 3 points. Then fourth point is, what we always do is, we look at the mitral aortic velocity integral ratio. Mitral velocity integral ratio in versus aortic velocity ratio, more than 1.4 is considered as severe. Then we look at a regurgitant volume, either direct method or by PISA, to be more than 60 ml. So that's what somebody was asking a few minutes back. What is the use of calculating stroke volume at mitral valve? So we utilize the stroke volume at mitral valve and LVOT. Suppose mitral valve stroke volume is 20 and LVOT stroke volume is only 60. If there's no other outlet, 60 ml blood is going back into the LA. So this is how we look at mitral regurgitation. TRZ severity, as I showed you, vena contracta. Vena contracta with less than 3 is mild, 3 to 7 is moderate, more than 7 to 14 is severe, 14 to 21 is massive, and after 21 is torrential. This gives you a type of severity of TR. But the TR is dependent more on gradient, that is TRZ gradient or RV systolic pressures. The severity of TR is useful when we look at the annuloplasty of a tricuspid valve or repair of the tricuspid valve or tricuspid regurgitation jet width. So two different places, tricuspid. If you look at the severity of TR tricuspid valve, we need to look at pulmonary artery pressure. If you look at the severity of a TRZ, that is used for calculating the, or for correction purposes, that you do annuloplasty or tricuspid valve repair or replacements.
Okay, sir. Okay, thank you, sir.
Right. Dr. Neeraj Dodke, some more questions?
Sir, what is the normalcy in mean pulmonary artery pressure and mild, moderate, and severe?
Pulmonary artery pressure for what? Mild, moderate, severe what?
The pulmonary hypertension, like peak you said no, less than 25 is normal and more than
25 to 35 is mild, 35 to 45 is moderate, more than 45 is severe.
More than 45?
Mean.
So 25 to 30 is mild, no?
25 to 35, 35 to 45, more than 45.
Okay. Thank you. So one more topic.
Pardon?
So one more topic was there here, the knobology. So will it be covered?
Knobology is like we will send you a video recording of knobology. See it again and again.
Okay.
Have a recorded knobology, see it again and again. Because problem with knobology, what we have been facing is everybody has got his own machine.
Yes.
And every machine has got a different knobology. Although work is same. Suppose in the screen I can show you. Just wait a second. I'll give you a show you the knobology points of view. Just give me a second. Yeah, screen last. So I'm reducing my like machine. Now you can look at this machine over here. So just a second. Let me just make it one. Correct. So in this machine, this is Vivid E95. In this machine, look, there are buttons are there. So first of all, this button is freeze. So I'm unfreezing it. Look, my machine has become unfreezed. Now this 2D button is there, not just burn part to single image of a 2D machine. Now this M mode. So I'm doing this as M mode. Switch off M mode, I'm going to colors. Look, I'm going to colors. So this is color box which has appear over here. Then switch off colors. Then I need a cursor. So there's a button we need a cursor. Now look at this cursor. This cursor is, if I want to take a continuous wave Doppler, I can keep like this. If I want to take something over at a specific point, so I take my cursor over here and then press PW. So I'm pressing PW. Now look, my cursor has taken a PW, and if I have measured this PW, so this will give me a pulse wave Doppler spectrum pattern. Just below this pulse wave, there is a continuous wave Doppler spectrum pattern. Correct?
Yes.
Then, if you go further, this is a button for measure. So you find everything opening up on the right hand side of the screen. Your machine, sorry, Knobology. Look, now this is all, once you press a measure, everything has come on this side. Whatever you want to measure. So this is what the word measure is. Then behind this, this is caliper. Caliper means you want to measure something at instantly. So you measure from this point to this point and instantly can measure over there. Then image store. Here is a point for image storing. So I can store this image. This is a QRS cycle. I'm storing this image. And look, as soon as I store, it will come and occupy in the left side of my screen. Then left hand side, this is auto, this is cursor, and this is angle. This is for 3 dimensions. And this is for freeze button. So what you need majority of time, you need a 2D emission images, M mode, color, then CW, PW. This is tissue Doppler imaging. So we will come back to this later on. This is tissue Doppler imaging or tissue velocity imaging. And then on this, look, there's a buttons of width, reset. Look, I'm focusing it gradually. With reset is look at the width of the, look at the width. I'm reducing the width of the sector. Can you see this width?
Yes, sir.
Similarly, tilt. Look, I'm tilting this. At your level, you may not understand what is the utility of this tilt. When we do a 3 dimensions echo, we have to adjust our RV into this sector frame. So we utilize tilt. So I'm using my tilt. Then this octave. Octave is frequency. So I'm using my lowest possible frequency, that is 1.4 to, it will be very difficult to see over here, but you can see on the screen, on top of a screen. Here you can see the frequency 1.4 to 2.8. I can increase the frequency. Suppose I've got a patient who is about 10 years old. So I need to change his frequency from this probe of 1.4 to 2.8 megahertz probe. One probe I can go to almost to 1.7, 2 meters, 2.2 megahertz. Sorry. So I can utilize this probe over here. Then rotate and reset is not required. How many cycles of QRS complex you would like to store in images? So this is a button. You can increase the cycle of 1, 2, 3. How many cycles you like to store in your images? So this is all is Knobology. Virtually all of them are same, but they are variable from machine to machine. So this is 2 dimensions gains. Now look, this is gains are increasing by 2 dimensions. Similarly, we have TGCs over here. This is trans gain compensation. I can increase all TGC to maximum now. Suppose I have more gains on a 0 to 5 centimeter of depth. So I'm reducing my 0 to 5 centimeter depths. Now 5 to 10 centimeters of depth. And then 10 to 15 centimeters. So wherever I want to adjust my gain, I can adjust this gain automatically with this trans gain compensations. Overall gains, 2 dimensions gains. There is a word which is known as depth. Now look, depth, I'm changing my depth. Look at this cursor sign which is increasing. This is 10, this is 5. Normally we keep a depth of 15 centimeter. So my image shows 15 centimeter over here. There's one more function which is known as zoom. So I want to say something zoom. So I zoom. Suppose I suspect some vegetations, I'll go to the zoom word and try to focus on that particular subject, that particular point. And those people who have got a machine, believe my word, sit down with the machine and play with the machine. The best part is, suppose you have to press something wrong. What is going to happen? Switch off that machine, switch it on again. It will go to the factory setting automatically. But you will have to play with the system, play with the machines. And those who are really looking forward to learn echocardiography, take my words, all of you should spend about a day, every day, 1 hour to 2 hours on practicing one subject. And at this moment, just on MO 2D imaging qualities. Any other questions before we stop? We'll be sending video recording to all of you. Then you can see this video recording and then we can go it further. Dr. Sachi Surendran again. Hi, Sachi.
Sir, what is the difference between RVSP, right ventricular systolic pressure, and mean pulmonary artery pressure?
Okay. RV systolic pressure is the pressure gradient between RV and RA.
Okay, sir.
Clear? Then mean pulmonary artery pressure is, that is pulmonary artery pressure at one particular point. We look at all the flow velocity which is going through the pulmonic valve. What is the average pressure of those?
Okay, sir. Mean pulmonary artery pressure is the significant thing for pulmonary hypertension.
Whenever we talk of pulmonary artery pressure, we always talk of mean pulmonary artery pressure.
Okay, sir.
Dr. Humaya Akhtar. RV? RV focus view. Is that right? RV focus view is, if you are asking for RV focus view, is go to 4th intercostal space instead of 5th intercostal space in apical window. Then LVLA will be cut off and we will be focusing exclusively on RVR. Dr. Janvi Jayawant, you can post your question on the WhatsApp so that I'll be able to answer you much better. Your mic is disturbed, just post on a WhatsApp. Dr. Jayawant, Janhavi Jayawant.
The ECG was not
The correlation
of that ECG
with that of
with that
color Doppler.
color Doppler.
Correlation of ECG with color Doppler. Just a second. Correlation of ECG is done with a Doppler flow pattern. Look, this is the beginning of a QRS complex to end of a T wave would be systole. End of a T wave to beginning of QRS complex would be diastole. But all of us understand that aortic mitral valve closes and aortic valve open. There is a word which is known as isovolumic contraction time. Similarly, aortic valve closes, mitral valve open. That is known as isovolumic relaxation time.
Yes,
so
sir.
whenever we talk of a systole, we talk of a QRS systole of beginning of QRS complex to end of T wave. Whenever we talk about diastole, we always talk about diastole, beginning of end of a T wave to beginning of QRS complex.
Yes, sir.
That is not clear.
But that was not clear.
No, waves.
Waves.
The waves are not clearly seen like what you say T. So
Waves are not clear means?
is this what you are saying T is like a isoelectric line like we are seeing like that. So what we actually seen in ECG, they are not matching with that now, which lead like that. This is
End of
AVR?
a T wave. This is T wave. End of a T wave. You can change this complex. Well, unfortunately, the subject has gone away. You can change the leads from lead 1 to 3. We have an option to change them. You can see the beginning of torus complex and end of T wave. Dr. Mahatre?
Sir, what is a normal BTI?
Normal BTI, about 24 to 25 centimeters.
24 to 25.
24, 25 centimeters.
Okay, sir. Thank you, sir.
So, no more questions. I think that is the time to say, see you next week. With this word, let me just put an end to all this class, and thank you very much. See you next week with another class. Stay safe. Bye-bye.
Thank you, sir.
Thank you, sir.
Thank you. Thank you.
Thank you, sir.